Hi, y'all. I just wanted to introduce a couple of my friends from the emergency department who are going to be speaking with us today. Dr. Nate Kuppermann is chair of the Department of Emergency Medicine and a pediatric emergency physician. I think there's been a longstanding knowledge or relationship with the work being done through PECARN, the Pediatric Emergency Care Applied Research Network, which is based here at UC Davis, but I don't think we've ever heard from the guys in charge of it. So he's going to share with us some of the history of PECARN and some of the major publications and really groundbreaking changes in care of the injured child that have come from it. In addition, Dr. Daniel Nishijima is here as the Associate Director of Research in the Emergency Department and will be sharing with us some future studies that are going on through the PECARN network that we're also involved with. So Nate, you're welcome to speak with us today. Thank you.
Thanks. So yeah, thanks, Jacob. It's really great to be here, and good morning to everyone. Just a few words of introduction before Daniel and I start. Our departments have a long-standing history of collaboration and friendship with Dr. Farmer, Dr. Galante, and many others. And you've never invited me to speak to you guys before, you know. So it's really it's great to yeah, you're right. So it's great to be here. What we're going to be focusing on today is multi-center research networks, but with a focus on the evaluation management of pediatric trauma. And many of the studies we're going to mention, they're collaborations between your department and ours. So really it's sort of, we're talking about a lot of joint ventures. A couple of studies that don't come up, but I do want to give a shameless plug, really as much for your department as ours. Daniel and I are collaborating with Drs. Treppe and Stevenson on a consensus-based guidelines for transfusion triggers in the setting of pediatric trauma. The two of them have really been doing an outstanding job, and we hope to come with guidelines and a publication with that soon. And we've been recently funded for a large randomized controlled trial of antibiotics versus laparotomy for pediatric appendicitis. Dr. Hirose is one of the site PIs here, so that will be an interesting study coming down the pike. And I just plug those now because we won't be talking about them in the talk. So thanks again for having us here. And what I'm going to do is I'm going to give a little bit of background of the PECARN network, as Jacob mentioned. Then I'll turn it over to Daniel, who will be talking about a really big, important trial that our two departments are collaborating on together with regard to TXA in pediatric trauma. And we have no disclosures to report except for that we're funded by the NIH for this TXA trial that I'll be talking about. So again, the objectives: a quick history of PECARN, Pediatric Emergency Care Applied Research Network. I'm going to talk a little bit about a couple of studies that we've done in the past, and then really the focus will be on the present and future, and specifically the TXA trial. So just a quick background of how do research networks evolve and how do they start. And so PECARN, I'm just going to give you a 1-minute primer on that. We had a collaborative research network in the Academy of Pediatrics, noting that to do research in pediatric emergency care, you never get enough outcomes at any one center, even any one big center. So we had a unfunded network in the early 90s, which I chaired for 5 years, and we actually had some big publications that came from that. And then the federal government came to us and said, well, what do you need to improve to make it better? And that was answer is easy, just we need money. And so they created EMSC, which stands for the Emergency Medical Services Program. It's a program under HRSA, the big federal funding program. They announced a request for applications in 2001 to create this research network called PECARN. We applied here at UC Davis as one of the nodes. We were funded in 2001, and we've been continuously funded since that time. And what it is, it's the first federally funded research network in pediatric emergency care. There are equivalents in other parts of the world, but we're the only one in the United States. We consist of 6 nodes. So whether you know it or not, our node here consists of 3 hospitals. UC Davis, we oversee our node, University of Pennsylvania, and University of Utah. We see more than 1 million children annually in the 18 emergency departments, so we're greatly powered to do big observational and randomized trials. And in our history, now we've been at it for 15 years, we have more than 100 publications, lots in high-impact journals. We've received more than $100 million of NIH and other funding. What the federal government does is they provide some infrastructure support for the network, but then we have to go out and chase NIH and other monies to do our clinical trials. And just in quick, this is just the schema of a research network. We have a big steering committee, and I will tell you the sort of the secret sauce of PECARN is we have these subcommittees that are really important. Feasibility and budget subcommittee, grant writing subcommittee, and these are the 6. You see 7. There's 6 nodes, but there's one node that focuses on pre-hospital research. The power of the network is that to get a research concept through PECARN is difficult. You get beaten up a little bit, kind of like M&M here. You're going to take your hits, but things that you learn along the way. But once a concept makes its way through the process, the NIH funding success rate has been about 80%. So you take your hits going through, and we throw out a lot of concepts, but the ones that make their way through have a very high success rate of being funded. And here you can see the sites in PECARN and us, kind of the lonely West Coast place. We've got a couple in Utah and Arizona, but greatly centered in the East Coast. And just to give you an idea of the types of research that we do, we're not focused on any disease entity. We're really a broad network. The ones I have in bold are the ones in trauma. So we're disproportionately represented in trauma because at UC Davis, we write a lot of grants about pediatric trauma, and they've been funded. But a couple of others I just want to point out that are not trauma, but of interest. Well, this was our first big hitter, by the way. This was a randomized controlled trial of steroids and bronchiolitis. Bronchiolitis is the most important respiratory illness in children. And at the time, children like crazy were getting steroids. We're talking about 2-month-olds, 3-month-olds. And we did a trial of 600 patients, showed no difference, and that was published in New England Journal. This was a randomized trial of magnesium for sickle cell pain, recently published in Blood. These are 2 that you would be interested in. 2 randomized trials of therapeutic hypothermia after pediatric cardiopulmonary arrest, showing no difference in both out-of-hospital arrest and in-hospital arrest, both published in New England Journal of Medicine. So we've had some big successes in publications. But what I'm going to do is just focus on a few trials that we've done in trauma, and then I'll turn it over to Daniel for the last 20 minutes. So this one I've mentioned, I've discussed in smaller settings here with you, but I haven't spoken about it in a large setting. This was our first sort of big trauma study in PECARN, which was a decision rule for neuroimaging after head trauma. And the goal of this study was to derive a decision rule to identify children as essentially 0 risk for clinically important brain injuries after trauma. And you can see the numbers. In a network, you can accumulate big numbers. We had 54,000 eligible patients in the network over 3 years to create these decision rules. We were able to enroll 42,000 of them, a lot, big enough to both derive and validate prediction rules for children younger than 2 as well as those 2 and older. And here are the rules, and I'm just going to highlight the similarities for the patients younger than 2 and older than 2. Severe mechanism of injury is in both of the rules. A history of LOC or altered mental status is in both the rules. But really importantly is how one is supposed to interpret the rules. The rules are meant to be interpreted by the absence of any factors. If you don't have any of the factors, you don't need to CT the patient because their risk of injury is less than 1 in several thousand. But it does not necessarily mean that if you have one of the factors that you need to CT scan the child. The risks are still pretty low. It was really meant to just identify those at very low risk. So this is how you would interpret these rules. And we have this as an icon on the EHR. Many of you have used it that help guide you through the process. But these are the recommendations for children younger than 2. What you can see is that if you have none of the 6 risk factors, I won't go through what those are. This is just, you can access it, of course, on the article and on our EHR. But if you have none of the rules, you're at extremely low risk, less than 1 in 5,000. You should not get a CT scan. But if you have one of the factors, if you have one of the high-risk factors, which are, I'll point those out, is that if you have a GCS that's less than 15 or a sign of skull fracture, the risk of a clinically important brain injury is about 1 in 20, so you'd get the CT scan. But if you have one of these medium risk ones, you can observe versus CT. And then for children older than 2, it looks really similar. If you have none of the risk factors, the risk of a clinically important injury less than 1 in 2,000. If you have one of those 2 high risk factors, which are the same, altered mental status or basilar skull fracture, risk about 1 in 25, you would get the scan. But if you have one of these medium risk factors you can observe versus CT. That was published in Lancet, and since then it's been validated in networks around the world. And CT rates, I'm not saying as a result of this study per se, but if you look at the trend of CT rates in children over the last 5 years, they had peaked 5 years ago and now are really have gone down quite a bit. A comment about knowledge translation, and I really like this slide. This slide was produced by Glasgow and Haynes, who are kind of grandfathers in evidence-based medicine. And one of the things that we're wary of in research networks is that we create all this, knowledge, but then how do you get the clinician to use the knowledge? That is a science in its own right, and PECARN is involved with doing knowledge implementation and dissemination. And this, I just want to highlight, this is the knowledge generation pyramid from studies, systematic reviews, etc. And you create this massive pyramid of knowledge. And then what happens, here's the pipeline to get to the patient. And you encounter, after you generate all this knowledge, myth and opinion and these are all the obstacles that allow water to leak from the pipeline before it can get to the patient. And you have to overcome these by doing a lot of interventions. These are bedside evidence-based practices, QI interventions, decision aids, etc. And the goal, of course, is to keep that pipeline full until it reaches the patient. So we did a study on implementing those head injury decision rules in EPIC, and the goal was to develop and pilot test a data template to gather information on the EHR, and then it was a trial to see if you could sort of put it in the face of the clinician, would it decrease the inappropriate use of head CT scans. It was a 13-center trial that we participated in here, and this is what the template looks like. This template takes about 30 seconds to complete. It has all the variables of the PECARN rule, and you would fill those out, and on that particular patient, and if you forget one of the variables, for example, what does it mean to have signs of altered mental status, you can click on the icon and it'll give it to you. And you put it in, and it'll give you this output. And it gives you two things. One is a recommendation that the head CT on this particular patient who is low risk is not indicated, but it also gives you what exactly that risk is. So you can decide whether you want to use the risk estimate or you want to use the recommendation, either way. And the results of this trial, these are the sites in which it was implemented. Overall, the rates of CT scans went down from about 20% to 17%. Doesn't seem like a lot, but it was significant. I do have to point out, it's not your guys' fault or our guys' fault, but a culture here at UC Davis. At UC Davis, if you look at the before CT rate, we're the 48%. Look at all those other numbers, and this is all risk adjusted. So these are same types of patients, and we have a culture of CT. The good news is that if you look at this baseline rate of CT use now at UC Davis in the ED, it's 23%. So either the rule or a combination of factors has greatly impacted us. I'm going to just quickly run through a couple more because I don't want to take from Daniel's time. We did a similar study led by Jim Holmes of identifying children at low risk for intra-abdominal injury who didn't need CT scan. It was a study in which we enrolled 12,000 children over a few years, again in collaboration with your department. Similar process as the head injury rule. Out of 12,000 patients, there were 760 with intra-abdominal injury and 200 of whom needed intervention. I want to highlight one thing that's really important when you compare single-center studies versus multi-center studies, because there's benefits and drawbacks to both. When Jim and I did the single-center study with you all in 2002, we came up with a really good decision rule, but it included a few laboratory tests. Then when we took this to PECARN, we got a big grant funded, and we wanted to replicate it. The problem is in 20 centers, we couldn't get everyone to follow the protocol. So laboratory tests were missing on a lot of patients. So this became, in PECARN, a prediction rule just of history and physical examination findings. And we knew we were we were nervous about it because a few of these laboratory tests we knew were important. So we did this study though, and these are the 7 factors. I'm not going to read them all, but the bottom line, there's 7 historical and clinical factors. And if you don't have any of those, you can see your risk. There was actually 5,000 patients of the 12,000, where's the 12,000 up there, who had none of these 7 factors. And if you don't have any of these factors, your risk of injury, you can see there on the slide, is 0.1%, very low, and we would recommend not getting the CT scan. But of course, you want to know who were those 6 patients that we missed. First of all, this is the overall test accuracy. The sensitivity was pretty good, but there were 6 patients that were missed. And this is the skeleton in the closet of multi-center research. There were 6 patients. Now, interestingly, 4 of the patients who were missed were at one center that we looked at the case report forms, and they were like kind of just checking off stuff. But you have to accept what is given. That was not our center. It was a center, some other named center across the country. But you have to accept that. But interesting to note, all 6 patients who were missed by the rule had either hematuria, elevated LFTs, alcohol on board, distracting injury. These are all factors that we found on our single center study 17 years ago. I think we did with Dr. Wisner way back when, highlighting that when you do it single center, you have control over it. When you do multi-center, you lose control, but you get big numbers. And all patients had hemoperitoneum. I'm just going to skip through this slide. This was sort of an algorithm that we developed as a result, and that was published in Annals of Emergency Medicine. I want to just quickly talk about the last study, and then I'll turn it over to Daniel. This is the controversy over FAST in pediatric trauma. An ongoing controversy. Should we put the ultrasound on the pediatric trauma patients? And here you can see the arguments against and for. Arguments against it is that it's insufficiently sensitive. Most intra-abdominal injuries we know are managed non-operatively. It can give you a false sense of security because we know the sensitivity of the FAST is about between 60 and 70%. And in older days, it doesn't happen so much anymore, but if you saw a positive FAST, you'd have an inclination to want to take the kid to the OR when it really was not necessary. But there's arguments for using the FAST, particularly in the unstable patient. We consider that standard of care. A hypotensive pediatric trauma patient, of course, you need to know why they're hypotensive. You would put the FAST on. It's available at the bedside. We know there's no radiation, and it can risk stratify patients. So what we got a grant from HRSA to do a randomized trial here in collaboration with several members of your department to look at the FAST. And we had anticipated, our hypothesis is that doing the FAST was going to decrease CT rates. It was done from 2012 to 2015. And just to note here, all we were looking for was free fluid. So we're not trying to identify injury on the FAST or look at the lungs, just look for hemoperitoneum. And our outcome measures were the CT rate, missed injury, the time of ED disposition, and changes of clinician suspicion pre and post FAST. And here were the results of that trial. There was 950 patients enrolled. You can see the baseline, all the characteristics were the same in terms of age, sex, etc. And here are the outcomes. If you look at, again, this is the group that received FAST and the no FAST group. The CT rate, essentially identical. The rate of intra-abdominal injury between the groups, identical. The time in the emergency department, identical. So one slide that, though, was quite interesting to us. What this slide shows is the clinician, we asked them their suspicion of injury before the FAST, from less than 1% to greater than 50%, and then their suspicion after the FAST. The green diagonal cells show that there is no difference between pre and post FAST. The blue cells are when that suspicion decreases after the FAST, and the orange cells when they increase. And what we found is that the post-FAST suspicion definitely decreased, particularly in those patients with a low pre-existing suspicion of 1 to 10%. And if you tally after the FAST, you can see there was 173 patients. The suspicion was less than 1% after the FAST, but nevertheless, we CT'd 49 of those. All of them were negative. But be that as it may, it was a negative trial. But there is probably some lessons to be learned about implementation there. So it did not, the FAST did not decrease CT use compared to controls. There was a trend in the youngest patients, and those are the patients we're most concerned about in terms of radiation risk. So we are now submitted a grant to do a large multi-center trial specifically powered around the younger patients. There was no difference in missed intra-abdominal injuries. It did decrease clinician suspicion, but it didn't translate into decreased CT use. So there is probably some future research that needs to be done around what is the appropriate use of FAST in this setting. And this was published in JAMA just a couple of months ago with members of both of our departments. So with that, I'm going to turn it over to Daniel to talk about an important trial that we are doing and the future of pediatric trauma research in PECARN.
Thanks, Nate. I'm going to talk a little bit about this traumatic injury clinical trial evaluating tranexamic acid in children, or the TIC-TOC trial. Nate and I have been working on this trial for, 3 years now, and hopefully subsequent years as well. Nate and I are the co-PIs in R34 award from NHLBI. So as you can see here, this is a table put out by the CDC. Trauma is a leading cause of morbidity and mortality in children in the United States. So in trauma are the blue dots on the table. We also know that hemorrhage is the leading cause of death in the first 24 hours. So exsanguination are the blue bars, and then it's followed closely by mostly TBI or CNS injuries. Unfortunately, there are no drug treatments for injured children to improve outcomes. So this is a drug, TXA, that you all are probably very familiar with. It's an antifibrinolytic agent. It's frequently used in pediatric and adult surgery. It's very inexpensive. It's less than $100 per use, and overall has a good safety profile. It's been around for decades. So if you look at panel A on the left-hand side, tissue plasminogen activator, it binds with plasminogen to form plasmin, which subsequently degrades fibrin clots. TXA essentially binds to both plasminogen as well as plasmin, preventing the formation of plasmin and preventing the binding of fibrin. So after tissue injury, our body typically there's a balance between coagulation and fibrinolysis. But often after severe tissue injury, you see an release of TPA that leads to increased levels of plasminogen, increased formation of plasmin, and you have this premature fibrinolysis and clot breakdown and excessive bleeding. So TXA essentially halts that process. So there's been multiple studies on adults with surgery, as well as with kids with surgery, also in patients undergoing coronary artery surgery, and then recently TXA use in postpartum hemorrhage. All these studies really demonstrate that there's robust surgical data that TXA is effective in decreasing blood loss and transfusion requirements, both in adults and children. And it has an excellent overall safety profile, both for adults and children. So the thought was that if it works well in surgery, why not in trauma? This ultimately led to the CRASH 2 trial, which I think many of you are familiar with. It was conducted by Ian Roberts in the UK. They enrolled over 20,000 adults with significant hemorrhage. Quite an accomplishment for a trauma trial. It was conducted in over 40 countries. Patients were randomized to either TXA or placebo. And as you can see, there was a reduction in all-cause mortality by 1.5%, with the number needed to treat at 67, and there was no increase in adverse events. An exploratory analysis also demonstrated that the earlier you give TXA, as you see for this forest plot, with TXA showing improved mortality in those with, if you give it less than 1 hour, and then also if you give it in less than 3 hours as well. And there is some suggestion of harm if you give it over 3 hours or greater. So that's why our protocol is we give it less than 3 hours. So ultimately, TXA in trauma is the first drug to demonstrate improved outcomes after trauma. Again, this is in adults. Cost-effective analysis demonstrated that it was cost-effective, that $64 cost per life year gained, and is added to the WHO list of essential medications. So the thought was, well, if it works in adults, why not kids, right? So the evaluation of TXA in pediatric trauma has been recognized as a key research priority for a number of groups, both in the United States as well as in the UK and Australia. And there was a recent article that also suggested, well, if the data is so strong in adults, why don't we just use it in kids? But we think that it's really important for us, before we start using it empirically in kids, that we should do a large clinical trial to investigate this. So this subsequently led to our funding for an R34, as I previously mentioned, and we're planning to do a phase 2 pilot and feasibility trial. We anticipate starting this trial in January. It's going to be conducted at 4 hospitals: UC Davis, CHOP in Philadelphia, Primary in Utah, Nationwide in Ohio, and then our data coordinating center is also going to be at the University of Utah. Trauma is a multidisciplinary disease, and so we're going to include trauma surgeons, physicians from emergency medicine, neurosurgeons, and transfusionists. So the overall objective of this study is really to demonstrate feasibility and subsequently inform the subsequent phase 3 clinical trial. And so we're going to learn about who we can enroll, who we missed during enrollment, our consent procedures, how well we can adhere to the protocol. Some of this blood transfusion guidelines that Nate alluded to earlier, a lot of that is making sure that we sort of reduce the noise so that we can best detect any potential signal from TXA. And so conducting this phase 2 feasibility trial will ultimately give us a better chance for success to pull off a successful phase 3 trial. And again, it's important to remember that this phase 2 trial is not powered to evaluate efficacy or safety. So inclusion criteria, we're going to enroll children younger than 18 years with evidence of hemorrhagic injuries to the torso or brain. There's essentially going to be 3 different strata. So there are going to be isolated torso injury, isolated brain injury, and as we know in trauma, we have some patients with polytrauma, both brain and torso injury. To be included in that both group, you would need to meet criteria for both torso and brain injury. So I'm not going to go through each of these specific inclusion criteria, but we have different inclusion criteria for penetrating torso trauma, as well as for blunt torso trauma. And again, the goal is to enroll a sick population. We don't want to dilute our population by enrolling patients with really minor hemorrhage. So if you can look at, we've spent a long time on this inclusion-exclusion criteria, but really the goal is to try to get a really sick population with definite torso or brain bleeding. And then again, for head trauma, GCS score 3 to 13 with associated intracranial hemorrhage on cranial CT. So here's a long list of exclusion criteria. So this is a flow diagram of how we are going to enroll patients. We're going to enroll them with informed consent. I'll talk a little bit more about this later. And then they're going to be randomized to 3 groups. This is going to be both the investigators and the patients are going to be blinded. It's going to be a TXA dose of 15 milligram bolus, as well as an 8-hour infusion of 2 milligrams per kilogram per hour. And TXA dose B is essentially double that TXA dose A. And then we're going to have a placebo arm as well, and then all patients are going to be followed for outcomes. So the rationale for choosing these 2 doses is dose A is essentially the equivalent to the adult dose that we currently give, 1 gram and 1 gram. And that's thought to inhibit about 80% of fibrinolysis. Some prior work has demonstrated that this higher dose will effectively inhibit 100% of fibrinolysis. So that's the thought between choosing these 2 doses. We're going to use permutated block randomization. That means as patients come in and they'll filter into each of these different strata, we're going to enroll patients into both dose A, B, and placebo for each of the strata. Because we expect there are going to be more isolated TBI patients, we're going to cap that at 20 so that we can fill the other strata. And again, the outcomes that we're going to look for, again, with remembering that we're going to not detect efficacy or safety for this trial, we're going to look at the PEDS quality of life, or the PEDS QL, which is really sort of a global function on how well the children are doing. So, are they doing well in school? Can they still ride a bike? Are they able to play with their friends? as well as the pediatric Glasgow outcome score. Again, this is another measure of global functioning. We're going to check memory through digit span testing. We're going to look at intracranial hemorrhage progression for those with intracranial hemorrhage, as well as total blood product transfusion at 40 hours. And we're also going to look at a number of biomarkers and adverse events. So here's just a list of the 3 different strata, as well as the outcome measures that we're going to collect. As those ones listed in red are those that we're just going to do for the torso injuries, and the intracranial hemorrhage progression of those just with the intracranial hemorrhage. So this is the schedule of events of what we're going to follow for the key outcome measures. As you can see, I just want to point your attention to the neurocognitive outcomes. We're going to capture it at 1 week, 1 month, 3 months, and 6 months. And the purpose for doing this is we are going to do an area under the curve of this outcome measure. And the purpose of doing this, rather than just doing a single point in time, say at 6 months or 3 months, is that we really want to change we really want to evaluate the improvements over time, because we think it's important. If kids get better at 1 month or 3 months, that's an important thing as well. So we're going to capture this area under the curve of the PEDS-QL. We're also going to look at a number of biomarkers to see if TXA use changes some of these key biomarkers. As you can see in this figure, we expect that with TXA, all these key biomarkers will be decreased. Many of you are familiar with TEG. As you know, it's a good measure to evaluate fibrinolysis. And so we're going to look at the lysis time at 30 minutes to see if TXA reduces the amount of fibrinolysis. Again, we're going to draw blood prior to drug administration, and then we're going to draw blood for biomarker testing at the end of the 8-hour infusion, again, to see if there's any changes in these biomarkers. Another thing we wanted to do was we want to measure TXA levels in the blood. And so we're going to check a blood draw at the end of the bolus, which is a 20-minute bolus. And then we're also going to mandate getting a blood draw at the ends of the 8-hour infusion, again, to measure TXA concentrations. We're also going to do some convenience sampling. If blood is already being drawn for routine CBC, for example, we're also going to collect blood at that time to see if we can spot measure the TXA levels both during the infusion and after the infusion. And this is ultimately going to produce a drug simulation model where we can see what the levels of TXA are. And this we're going to rely on some of our colleagues in the pathology medicine to put together this population-based PK model. So again, we're planning on starting enrollment in January 2018. We anticipate enrolling 1.25 patients per site per month, to a total of 40 patients. Again, this is just to look at really the feasibility. And this will ultimately, we're hoping this will ultimately lead to a subsequent phase 2, phase 3 trial. We anticipate this would be a multi-center randomized control trial, phase 2-3. It's a seamless adaptive trial. And it's going to be, we anticipate it's probably going to be over at 40 sites. There's a number of networks that might be candidate networks where this trial could be run in. We anticipate it's going to be in PECARN, but also this pediatric international pediatric emergency research network, or PERN, which actually Nate is chairing currently. There's also this national CTSA consortium that's also a potential consortium as well that we could run the trial through. And we anticipate enrolling over 1,000 patients in both with both head and torso injuries. And so we wanted to make this protocol for this pilot trial as close to the protocol as we expect for the phase 3 trial. So there's going to be a similar inclusion and exclusion criteria as overall study procedures. We anticipate the primary outcome measure for the head injuries are going to be area then curve for the PEDS-QL in the first 6 months, and then for those with the torso injury, PEDS-QL in the first month. The major difference that we think that we're going to be allowed to do, major difference between the protocol between the phase 3 and the current feasibility trial is that we anticipate the phase 3 trial will be run under exception from informed consent, because it's going to be a limited time window that we can actually get consent. The FDA, this is an FDA regulated trial, and so the FDA essentially told us for this feasibility trial that because it's just a feasibility trial that we should try to get informed consent. But for the subsequent phase 3 trial, they understand that that probably will need to be run as a EFIC trial. So that's what we anticipate for the subsequent trial. And we anticipate this probably going to NHLBI. They have this UG3, UH3 mechanism, or possibly NNDS. They also fund some TBI studies as well. And then they're also, because this might be an international trial as well, there's a potential for involving some international funding agencies. And that's it. I think we finished right on time. So Nate and I would be happy to take any questions, both on the content Nate presented on, as well as his TikTok trial.
First, I just want to say thank you, and that in addition to the details of these particular trials, just the whole process of developing big multi-center trials, big multinational trials, how to think about doing consent in patients that it's difficult to get consent, really important problems that you guys have a lot of experience with now, having done this in multiple iterations. I really appreciate you sharing, because the complicated part of putting these trials together, I think, is one of the great lessons, and I hope you actually contribute that to the literature as well. Just making the process. I think it's very complicated.
And I just want to also highlight, Anna, that really is, as we tried to echo in our statements, this has been, most of these studies, in fact, all of the trauma studies have been a great collaboration between our departments. I just don't know if it's been how well publicized in the department here, but specifically the section on trauma and also Shin with the appendicitis study, et cetera, been our great partners. Could not do it without you guys.
Thank you. Let's open it up for questions.
Particularly in the kind of difficult, smaller number feasibility phase, data safety monitoring and early stop rules, are these formalized in the submission? So you've thought about them and you line them up ahead of time. And then in the international trial, does that become a problem?
So let me give us a crack, and then Daniel, turn it to you. So on the TXA trial that Daniel presented, this is, as he mentioned, this is feasibility to show that we can do it. That is, NHLBI, they're probably willing to fund us, but not until we show them that we can actually capture patients and we can get drug on board within the first 3 hours. TXA, as many of you know, in the CRASH trial, it showed efficacy when administered early, but beyond 3 hours, it did not show any benefit.
Did they ask you to do the feasibility study first?
Yes, they did.
With the big trial, and then they said no?
So we spoke to the program officer, and they were very clear. Go for an R34. So for those who don't know, R34 is a planning trial. Show us you can do it, and then we'll come back and talk about the big trial. So yeah, they were very explicit. So there is actually a DSMB, so a Data Safety Monitoring Board, even for the feasibility trial, although it's mostly for safety, because we're not going to show any difference between arms with 40 patients. It's just to show that we can do the study. But they will monitor for safety, because if there's a trend with safety, they would let us know and it would stop. Daniel, you have comments?
Yeah, I will say, the amount of work that we put in for the R34 is probably almost as equivalent to sort of doing the big subsequent trial. I mean, it's for a much smaller amount. For the subsequent trial, we anticipate this would be a $8-10 million funding to sort of pull off that trial. And so I mean, it's NHBI is sort of getting a deal. I mean, we're really putting in the amount of work to sort of do the subsequent trial. Again, the protocol is going to be very similar. The DSMB is in place as well too. So.
And one thing I was going to mention then, Shin, is that you asked about internationally. So fortunately, PECARN is a very robust network, as we described. But they're in Canada, they have an equivalent network. It's outstanding. In Australia and New Zealand, there's a network called PREDICT. They just published a big study in Lancet. They're outstanding, and they're our partners. So they have the same processes already sort of in place, and they're ready to engage with us. Now, we only want to we like this sort of the kumbaya of doing it internationally. It does raise a level of complexity, but we likely will need them for the numbers and also for the generalizability. And this particular topic on TXA and pediatric trauma, it's, as Daniel mentioned, high priority amongst many people around the world. So, Shin?
I want to thank you both for coming and congratulate you on awesome work. And I just want to impress upon the residents in the room, this is an incredible amount of work that they're doing in a sense. It takes so much effort to get even these smallest things off the ground. It's very, very impressive. And thank you for your collaboration and for working with us. And I wanted to ask you a couple of things. And one is, so in my experience with the FDA, when they say it's a feasibility trial, they turn around and say, "No, show us your efficacy data." So are you guys collecting that as well, obviously, this pilot study?
Yeah, correct. Yes, you're exactly right. For the grants, we sort of titled it as a feasibility trial, but for the FDA, we said a safety and efficacy trial. So you're right. We're collecting both safety and efficacy data.
And my last point, I think, is probably the most salient for us locally, is that we have these great studies, and actually they're powered really well. And yet, as one of the key sites that publishes the data with you guys as first authors, we don't follow those recommendations, and it drives me bananas. And it's that paper that you showed, how you get the data from the study into practice. And I'd just like to ask, if there's other ways that we can help collaborate in getting the information. Posters and whatnot work, and these tools on the EML work, but there's got to be a better way to get us to actually do what's right.
Right. So, Sharon, I'm glad you raised that. That wasn't a plug out there, but it's interesting. There's two major ways of dissemination. One is the science of dissemination implementation. So that trial that I showed you, by the way, it looks like a simple trial. It was a $3 million study, that 13-center EHR trial. That's what it takes to do this kind of stuff. But the other piece is pure dissemination. So in PECARN now we're partnering with, if you guys go online, the residents might know this, although it's an emergency medicine thing, ALIUM stands for Academic Life in Emergency Medicine. It is the biggest social media site in emergency medicine, and it's run by Michelle Lin, who is at UCSF, and they are wizards at dissemination. So they actually took the PECARN head injury rule, and they turned it into a pictograph, and there have been tens of thousands of hits online. You could go and get it, and this is the way to disseminate. I mean, we do it locally, but there's not enough wall space for posters, and we don't have enough pocket space for pocket cards, right? So it has to be electronic in some form. And I will, kudos to you all, is that, our CT rates, I showed you, when we started the head injury trial, we were like 3 times higher than any site, but now our CT rate in pediatric minor head trauma, it is the same as any other children's hospital. So it's the power of, accumulated knowledge and dissemination in a variety of ways.
This issue of implementation science, is an entirely separate area of health services research that we are developing greater experience in, I think, throughout the institution. And I think a great example that came out of M&M 2 weeks ago around implementation was that nobody knew about the stroke protocol at UC Davis. This great thing that we have, and an unexpected patient had a stroke, not an expected patient on some other service, and like, what stroke protocol? So I mentioned that at med staff yesterday, and they were like, how could that be? The neurologists were like, we've told everybody 1,000,000 times. That isn't the same as getting the message to the people.
Yeah,
sure. So, really important.
Yeah.
First, I just want to echo Shin's comments about congratulations on this project. I wanted to ask you, with your high dose and your TikTok study, what are your concerns for constipation hypercoagulability with that dose, or are there any?
Yeah. Right. So Ian's referring to, there's some recent work primarily out of Denver that there's 3 different phenotypes, right? There's a hyperfibrinolysis, where we think that TXA probably would work the best. There's also this physiologic where basically there's, it's sort of a normal physiological levels of fibrinolysis, but there's also this fibrinolytic shutdown where there's maybe patients are a little bit more procoagulant and maybe potentially TXA may be harmful in those patients. So, I think a lot of that data is still early. We don't know in kids, right? A lot of this data is in adults. This is one of the reasons that we do want to collect data, TEG data and some biomarker data, and hopefully that may be something that we need to look at for the subsequent trial as more studies come out. But we definitely want to look at that in this current trial. So,
let me add, Daniel, what we do know, however, in pediatric surgery, so that our high dose is 30 mg per kg as a bolus. The low dose is 15 mg per kg, which was within the CRASH trial. But in cardiac surgery, people are giving 100 milligrams per kilogram. It was super high doses. And the literature out there in children, there's nothing in the surgical literature that really shows any increased risk of, PEs or thrombotic events. Seizures, there's a slight increased risk in seizures in cardiac surgery patients, although it's unclear, is it due to the TXA or is it due to the fact they're having cardiac seizures? So the data out there look like it's really safe, and that's why some people say, why are you guys even studying this? You should just start using it. But we know, first of all, the data around TXA is a bit controversial, and we don't know if there are differences in children than in adults, and that's the reason we're studying. But we're not really concerned about safety, although, of course, we're studying it.
Yeah, and the truth is we really don't know what the best dose is, and that's part of the phase 2-3 part of that, the subsequent trial may be a dose finding part of it, where we're going to use adaptive randomization to identify the best dose. So we're actually sort of simulating some of the simulations for that and planning for that trial.
Thank you again.
Great,
Really
thank you.
great.